Hello, and thank you for joining us today. We're going to review how to perform a labial gland biopsy in this video. First off, positioning. Once you've discussed risks and benefits of the procedure with the patient, it's time to position the patient for the procedure. I usually put them in a chair and stand in front of the patient. I cover them with a gown, draping it over their front before I start the procedure. Dr. Ike, why don't you please explain to our audience your unique body habitus and how you position the patient? I think this would be helpful.
Yes, Sarah. At 6'8", I am taller than the average rheumatologist. I found early on that standing while the patient sat on the examining table required me to bend over quite a bit, and that made me more clumsy with my hands than I liked. So I sat, and the patient sits on a regular chair in the examining room while I sit on the rolling chair for the doctor. I sit opposite to the side I'm going to be biopsying, so usually my right patient's left. I reach over and grasp the patient's lower lip from their right side, evert it, and perform the procedure as you've been describing. That seems to work well for me.
All right, let's go ahead and get started. Here we're injecting 0.4 cc's of lidocaine with 1 to 100,000 epinephrine, using a TB 30 gauge needle in a 1 milliliter syringe. I wait about 5 minutes, allowing hemostasis to occur, before actually beginning the incision. You can see the positioning of the incision is from medial to lateral, about halfway between the angle of the mouth and midline of the lip, and anterior-posterior, about halfway from the vermilion border to the gums. This provides optimal positioning because the labial salivary glands increase in density laterally, but it becomes more inconvenient to obtain the gland tissue physically as you extend laterally. Therefore, this position is optimal. What you can see here is that upon initial incision, we see glands right away and very superficially. I want to emphasize that the labial salivary glands live superficially, and you really shouldn't have to extend the incision very deep at all. Now what you see is we've removed our first labial salivary gland with forceps, and we're proceeding to remove the second labial salivary gland. Upon superficial inspection, we don't see any additional labial salivary glands. I could potentially extend the incision a little bit more. However, instead what I'm going to do is use the incision that I've already created as a sort of window, and I can move it around this very superficial incision such that we can potentially see additional labial salivary glands using this window without having to extend this incision, which I would never want to extend more than about 0.5 centimeter if avoidable. You can see that I'm pointing out an additional gland I could see by moving the window. I'm just releasing a little bit of connective tissue there, and we're going to remove another labial salivary gland. Here we're going to go ahead and place our dissolvable chromic gut suture. We start within the defect, extend out through intact tissue, we then enter again through intact tissue and exit through the defect. This is a simple buried suture.
Sarah, I'm sure you'll recall that mastering this little stitch might be the hardest part of learning this procedure. The stitch is opposite what we all learn to use to sew up a simple laceration. Difference being that for this stitch, the knot is buried below the surface as compared to the laceration stitch where the knot is on the top. To achieve this, you take your needle and penetrate the mucosal defect, come up through the mucosal surface, come across to the other side of the incision, and penetrate through the mucosa, bringing the needle back out through the tissue defect, then bringing both ends of the suture up to tie your knot, which you'll be demonstrating.
We will then cut the suture right above the knot, leaving two little tails. And the next thing to do is to tuck the knot into the incision, burying the knot for the comfort of the patient and to avoid the discomfort of the knot rubbing on the gums before the suture dissolves. I usually at this point provide the patient with post-care advice, which you can see in the associated PowerPoint, and send them home with an ice pack and these care instructions. Thank you.